Kumar.
Very good afternoon to you all, dear and esteemed delegates, my friends and colleagues in Tripura. Warm greetings from Kolkata in these very difficult times. So, I have been asked to talk on heart failure management today, case-based approach. This is, as you can well appreciate, is a very vast topic, but I will try to be as crisp as possible while covering all the aspects of heart failure management. But definitely, I'll be missing out on some points, so I beg to be excused on that ground. As you know, heart failure these days, I mean, it's not a very heterogeneous population. And if you want to broadly classify cases of heart failure, the broadest classification is HEPREF and HEPPEF, that is heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. Here on the left-hand side, you can see a prototype of a PrEP patient, Mr. X, 55 years old, male, generally, but definitely can be a lady as well. A BMI within a normal range most of the time. In this case, he is a diabetic, had an anteroseptal myocardial infarction, which was not revascularized in proper time. So the LV ejection fraction is poor, 35%. He has a long class 2 history of shortness of breath. And recently, over past 2 weeks, he has decompensated. So at presentation, he was class 4, presenting to the intensive care unit of a hospital. On the right-hand side is Mrs. Y, 65 years, female, typically, but again, here we can have a male patient here, but more often with HEPPEF, we have a elderly lady presenting to us. BMI in the higher range, overweight range, both diabetic and hypertensive. Echo showed increased left ventricular mass, left atrial enlargement. Ejection fraction was normal, that's why it's a HEPF. The patient has a shorter history of 2 weeks, but has acutely decompensated over past 1 week and class 4 again at presentation. So when a patient of acute shortness of breath with feature suggestive of heart failure comes to us, we are not sure at presentation whether it is a HEPREF or a HEPPEF unless the patient is known to us from beforehand or from his or her records. So acute decompensated heart failure can be because of LV systolic or diastolic dysfunction, or at times it can be combined with or without additional cardiac pathology such as coronary artery disease or valve abnormalities. However, a variety of conditions or events can cause cardiogenic pulmonary edema due to an elevated pulmonary capillary wedge pressure, even in the absence of heart disease like primary fluid overload, secondary to blood transfusion, severe hypertension, particularly renovascular hypertension. And we commonly face this kind of a situation in severe renal disease as well. So our first approach to a patient of acute decompensated heart failure would be airway assessment and continuous pulse oximetry to assess adequate oxygenation and ventilation. And we should institute supplemental oxygen and whenever needed, ventilator support, either non-invasive or invasive as indicated. I'm going to come to this in the next couple of slides. Vital signs should be closely monitored, especially with regard to hypotension or hypertension. Continuous cardiac monitoring for any arrhythmias. Intravenous access should be instituted as quickly as possible. Patient should be propped up. Prompt diuretic therapy. There is a lot of importance in this. I'm going to refer to this as well. And if diuretic therapy is alone not enough, especially if patient has significant congestion with adequate blood pressure or has actually severe hypertension or acute MR or acute AR, vasodilators become a must. Later, of course, we give in the chronic phase different types of vasodilators, which I am going to discuss at the end. And urine output of the patient should be closely monitored, preferably with a urethral catheter placement. Now, non-invasive ventilation should be given to as many patients as possible to reduce the work of breathing. But mind you, there are definite contraindications for it, where it should not be given, like need for emergent intubation, cardiac or respiratory arrest, severe respiratory distress, or unstable cardiac arrhythmia. Here, patient should be intubated and mechanically ventilated. There are a number of relative contraindications due to constraint of time. I cannot discuss all of them, but mind you, if the patient cannot cooperate, is semi-conscious, drowsy, airways do not appear to be protected, or there are a lot of secretions. Again, here non-invasive ventilation should not be given. So we should make a proper choice and decision which patients are to be intubated, because intubation should be timely, it should not be delayed unnecessarily. Wherever a non-invasive ventilation is not applicable, when patient fails to maintain adequate oxygenation or airway protection or both, patient should be intubated. Now, diuretics are an emergent therapy in acute decompensated heart failure, and it is the first choice of pharmacological therapy in these patients. IV furosemide or torsemide, whatever is the particular individual physician's choice, should be instituted at the earliest, preferably within 60 minutes of presentation. And if it is given early, it was found in a prospective observational study of 1,200 or more patients that it lowers in hospital mortality compared to later treatment. And of course, if the diuresis is delayed, the risk of mortality increases steeply during the first 100 minutes, but of course later on it levels off. So these are the typical initial dosages of furosemide, but mind you, if there is no initial response to the first dosage, one should never hesitate to double the dose at 2-hour intervals as needed up to the maximum recommended dosage. And many of us not only give bolus dosages, but I particularly prefer intravenous infusion after the initial bolus, because that kind of maintains a sustained hypotension. Often our nursing staff are morbidly afraid of giving diuretics in hypotensive patients. So often the bolus dosages are withheld without our knowledge. So I always prefer giving after the initial bolus dose has worked, I maintain the patients on a continuous intravenous infusion. And the rate of infusion, if the eGFR is in the normal range or close to normal, we give 5 milligram per hour or even less at some, for torsemide. But if the patient has a compromised eGFR less than 30, they need higher dosages of even 20 milligram per hour. Now, giving diuretics is not enough. We should not only look at their efficacy, that is their power to increase urinary output, but always one should look at the volume status, evidence of congestion, and the oxygenation status, daily weight monitoring, fluid intake of strict fluid intake output chart should be maintained. One should monitor the electrolyte abnormalities, symptomatic hypotension, mainly postural hypotension, and a very important thing that I'm going to discuss separately is worsening renal function and metabolic alkalosis. Now, and I forgot to mention that it can, in some patients, can also precipitate acute gout. So, management of worsening renal function, this is often a point of confusion for many of my colleagues. I have seen that a patient after diuresis has elevated or rising burn and or serum creatinine, what to do? One should exclude other potential causes of kidney injury, like use of other nephrotoxic medications, urinary obstruction, etc. If the burn rises, but there is still signs of severe symptoms and congestion, severe symptoms and signs of congestion, one should persist with diuresis. Especially, one can do a bedside echocardiogram to look at the E by E time ratio on the echodoppler, or look at the IVC diameter and its response to a sniff, as we say, to find out the central venous pressure. And these patients with persistently raised central venous pressure can still benefit from diuresis even if the burn is rising, but the creatinine is more or less normal or increased minimally. But of course, when the rise in creatinine actually takes place and we doubt intravascular volume depletion, then we can temporarily discontinue the diuretic, increase the hydration part a little bit, and even withhold ACE inhibitors or ARBs if they have been given. In some cases, we need adjunctive inotropic therapies in these patients to increase renal perfusion, because if the arterial blood pressure is low and the venous pressure is raised at times there is inadequate renal perfusion. So raising renal arterial pressure by increasing, by using inotropes can actually help renal perfusion. Then, of course, if diuretics have been found to be a failure, like a combination of a loop diuretic and a thiazide diuretic like metolazone, then of course one has to resort to ultrafiltration, dialysis, and often inotropes also come in handy in this situation. Now, when to use vasodilators? Now, nitroglycerin has been our favorite as an adjunct to diuretic therapy. This is particularly useful when the mean pulmonary capillary wedge pressure is particularly raised. So we often use this. But frankly speaking, there is only low to moderate quality evidence of clinical benefit. Some studies have shown that higher dose of nitroglycerin or high dose of IV isosorbide dinitrate is better than the lower dosage, but there is again limited evidence in favor of this argument. Use of nitroprusside in patients with ADHA is based largely upon expert opinion, since available published evidence is very limited. Now coming to salt and fluid restriction, we routinely do it, but with a salt restriction of 3 grams per day, there is the guidelines mention that, but again, safety and efficacy of salt restriction require further study. In fact, if the sodium is normal, low normal, or subnormal, one should at least give normal salt diet in these patients. Fluid restriction is again a routine management protocol, but again, stricter fluid restriction is indicated in patients with severe hyponatremia, sodium less than 125 or worsening hyponatremia, although patient tolerance of strict fluid restriction may be limited. Routine anticoagulation should be done. Tolvaptan is handy in patients with severe hyponatremia with cerebral dysfunction, but again, one should monitor the hepatic dysfunction consequences of tolvaptan. Opiates have been our good old teaching. That opiates are handy in ADHA, but right now we generally avoid opiate therapy in the treatment of ADHA. Now, what to do in hypotensive patients? Of course, here we have 2 choices: to either to use inotropes when there are features of inadequate cardiac output. That is the first line of choice. But frankly, if there is hypotension below 85 millimeters of mercury, vasopressors should be used, and here inotropes may not be that useful. In HepPEF, hypotension is a peculiar phenomenon. Here, inotropes should never be used. Vasopressors can be used very judiciously. Often, there is a phenomenon called dynamic Lvd obstruction, which not only occurs in HOCM patients, but also occurs in other HepPEF patients, particularly with a small ventricle. Here, inotropes can worsen the hypotension. We should very judiciously hydrate these patients, rather use beta blockers to relieve the Lvd obstruction, and in some cases use either phenylephrine or norepinephrine. So these are the vasopressors we routinely use. Norepinephrine is our most favorite choice. Epinephrine is in very refractory cases where norepinephrine is not working. Phenylephrine is not very commonly used, but it has the advantage of not causing arrhythmias, unlike other vasopressors. Dopamine is a good vasopressor drug. Almost equal in efficacy with to norepinephrine, but it can cause some arrhythmias. Vasopressin is a last resort in many patients where norepinephrine alone is not working, but it can actually, in patients with myocardial dysfunction, it can reduce cardiac output. Dobutamine is the inotrope of choice in patients first line in cardiogenic shock, but it can actually cause hypotension and a lot of tachyarrhythmias. So often one should be cautious in using the patients who have a systolic blood pressure less than 90 millimeters of mercury. Milrinone is the classic inodilator. It can be used in patients as a bridge therapy, those patients who need cardiac transplants or LVADs. Here they can be useful, but again, it can cause hypotension. Now, beyond inotropes, the mechanical cardiac support in the form of either IABP, ECMO, or short-term LV assist devices, or even biventricular assist devices can be a bridge to decision or bridge to recovery. And We can use them very judiciously in patients whose cardiac index is very low, blood pressure is less than 90, and CWP is more than 18, and who cannot really be maintained on inotropes and other drugs. Mechanical circulatory support is indeed very handy. So this is the sum total. We should differentiate other etiologies of acute shortness of breath before you come to a diagnosis of acute heart failure. Never forget taking a routine ECG and a chest X-ray and the routine blood parameters, including electrolytes, burn, creatinine, etc. ABG is very handy. And now NT-proBNP and BNP not routinely available in all the centers, but it is definitely useful when particularly bedside echocardiography cannot establish the diagnosis of acute heart failure. But bedside echocardiography is a must in all patients of acute heart failure. So treatment I will not repeat in the interest of time. I have discussed all of this. Coming to the long-term treatment for HFpEF and HFpEF, HFpEF is a very peculiar entity. Here patients have a lot of comorbidities, hypertension, diabetes, obesity, etc. All should be managed. If patients have AFib, heart rate should be controlled. In some cases, rhythm should be restored either with pharmacotherapy or if required with RF ablation. Then one should be maintained. This patient have to be maintained on a low-dose diuresis. But mind you, in patients with small ventricles, this can cause hypotension and azotemia. So one should be cautious. One should exclude concomitant coronary artery disease and treat it adequately. For patients who receive antihypertensive therapy, one should target a blood pressure of less than 130/80. HFpEF, of course, has a lot of disease-modifying therapy, and we should use all these disease-modifying therapies. In a recent European Heart Journal article, these four, ARNI, MRA, beta blocker, and SGLT2, have been termed the fantastic four of HFpEF therapy. We have more fascinating therapies coming our way, vericiguat, omecamtiv, and of course, right now we also have ivabradine to add to our armamentarium. So a lot of very fascinating and effective therapies are emerging in HFpEF. Many have emerged and more are emerging. So the two doyens of heart failure, John McMurray and Milton Packard, they have suggested this proposed new sequencing when we are discharging patients of HFpEF after initial management. Beta blocker and SGLT2 inhibitors first, followed by ARNI, and last by MRAs. So this is the new proposed sequencing they have suggested in a recent American Heart Association statement. And of course, each patient has to be individualized, but one should never forget the foundational therapies in patients with HFpEF. So, and beyond that, one should treat diabetes, AF, ventricular arrhythmia, CAD, anemia, hypertension, obstructive sleep apnea, and never forget, last but not the least, lifestyle modifications. All these are very effective in the long-term management of heart failure patients. And look at the number of ongoing trials in heart failure. Some of these trials, in fact, have already been published, are on the way to be published. So we are having some fascinating therapies, ARNI in heart failure with preserved ejection fraction, the new potassium binding agents, vericiguat. We are having omecamtiv, the first inotrope to show not to show an increase in mortality and to be effective in improving RV dysfunction also. Ivosimendan has been shown in a number of trials to be effective in short term at least. Then we have number of other treatments. The SGLT2 inhibitors have been a revelation in recent times in terms of improvement in heart failure hospitalization. IV iron in suitable patients are extremely effective, and the new potassium binders are going to make our lives easier, make our lives easier, because hyperkalemia is a problem in many of our patients. And not to forget, last but not the least, the number of devices that are coming our way. Not only the CRTD, but many other devices are coming. Again, I will not be able to discuss some of these, and not forgetting tafamidis in cardiac amyloidosis. So this is my last remark. This is where we are. We have achieved a lot already, but a lot remains to be achieved. I have discussed about HEPREF and HEPREF, but in the middle lies heart failure with mid-range ejection fraction. I mean, there is a lot of overlap between the two, and many of the therapies for HEPREF are now showing to be effective in heart failure with mid-range ejection fraction also. And this is the time of artificial intelligence. This is a time of individualized or personalized therapy, which will help us to tailor treatments, tailor services, and thus achieve novel endpoints and novel treatment targets. Thank you very much for your patient hearing.